This is our fourth patient on our virtual ward round. So this is a 64-year-old woman who essentially has had 6 weeks of progressive dyspnea on exertion with quite a significant reduction in exercise tolerance from 1 mile to 100 yards, but also 1 stone of weight loss in that time frame. Previously, not really had any significant diagnoses, not on any medications or any allergies or any family history of any great note. Quite a considerable smoking history with 60 pack years in total. On examination, normal looking set of observations. Respiratory exam reveals no clubbing, trachea central, no lymphadenopathy. But on the left lung examination, she has a stony dull bass on percussion note, no breath sounds in the lower half, and reduced vocal resonance. So these are all clinical features of pleural effusion. So chest x-ray kind of confirms our clinical suspicion, but I guess we should always try and report a chest x-ray with an open mind really before we jump to any conclusions. So just thinking about the report of this x-ray, we can certainly see there's considerable shadowing in the left mid and left lower zones. It's very dense shadowing, and as a result there's a complete absence of the left costophrenic angle. There's an absence of the left cardiac border, and there's a possible meniscus sign at the top of the shadowing area around the left mid-zone. So all of those features together, given the clinical examination findings, may be suggestive of an underlying pleural effusion. The differentials really in terms of, in other words, what's causing the pleural effusion. Obviously you need knowledge of different causes of pleural effusion, whether it's a transudate, in other words, some sort of issue with protein imbalance such as heart failure, renal failure, or liver failure, or is it more likely to be an exudate, in other words, some sort of infection, inflammation, or cancer. I think given the story of significant weight loss and the smoking history, sadly, I think cancer would be, certainly high up on the list, and certainly the main thing that we should look to exclude in the first instance, along with infection, which is in itself could cause a similar presentation to some extent, although probably not going to give you that extensive weight loss in such a time frame, but it might do. So just summarising that, really, the patient presented again to CDU, malignancy is high in the thoughts of differentials, infection could be there. PE can interestingly cause exudates and transudates, and again, it can actually cause, in some cases, significant pleural effusion, so it may well be something to consider, but again, the weight loss doesn't really fit with that story. So in terms of investigations, we clearly need some routine blood tests to look for infection. We might do some things which help us. For example, if we think about cancer, things like liver function tests, calcium, we can get hypercalcemia as a sort of consequence of lung cancer. So those kind of things may give some extra clues. And then really we need to get some fluid if that's what's the underlying issue. So there's only one way to safely take fluid out of a pleural space, and that's under ultrasound guidance or CT guidance, for that matter, but some sort of radiological guidance. And it's now become standard for thoracic ultrasound to take place, usually on patient wards. So rather than having to transfer patients to radiology units, we've got near patient ultrasound, which we can do. So essentially patients need to have real-time ultrasound, essentially to avoid any significant other structures. So in terms of patient safety, avoiding, for example, if you're doing a left-sided examination, you want to make sure that we're not going anywhere near the diaphragm, or certainly not below the diaphragm into spleen. Clearly we've got the left sort of ventricle and left side of the heart as well, which may also be fairly close. And on the right side, of course, there's the liver to contend with. So again, it's really important in real-time ultrasound that we are actually making sure that we are visualizing fluid. So therefore, if we're going to put a needle into somebody, we're going to take fluid out and not, go into one of these major organs that I've described. And then when we get diagnostic pleural fluids, we want to send it really for three different purposes. One is biochemistry, which will check the protein level, which is important to distinguish and clarify whether or not we've got a transudate or an exudate. We want to send some fluid for microbiology, which is very useful in terms of screening for infective causes. Sometimes it may be patently obvious that it's an infection. For example, if you aspirate what looks like to be pure pus, then clearly you know that you've already got an infective cause. But again, you can send it to microbiology for further culture and evaluation. And then also we want to send fluid for cytology, because again, we can pick up some cancer diagnoses from pleural cytology. If it's a very large effusion and the patient's breathless, like in our case, then we might want to take a fair amount of fluid off. So that's what we call a therapeutic tap. So that is essentially still with a needle and possibly a three-way tap or a pleural aspiration kit. We can take off, for example, 500 to 1,000 mils of fluid, which essentially will help the patient's symptoms in the short term at least. But we've mentioned, you notice in block capitals it says no drain. So essentially the reason why we've said no drain at this point is because we don't really know what the diagnosis is yet. So although we suspect that this patient has cancer, really to sort of clarify and to fully understand if they've got cancer, we need to know what the histology is, because clearly there are different types of cancer, and therefore it's important to understand what the underlying histology is, which will then influence oncological treatment going forwards. So without getting a biopsy, we can't have all that information. And actually, if, for example, you took out all of this patient's pleural fluid with a chest drain in the first time you met them, and then pleural cytology results come back as negative, because there is a chance of getting negative results with pleural cytology. I think about a third of patients have positive pleural cytology if they've got cancer, so it's not fully diagnostic. Then essentially you'd be left with a situation where you've removed all the fluids, but you've not actually got a diagnosis. So the way that we try and get a diagnosis is actually doing some sort of pleural biopsy, and the best way we can do that is something called medical thoracoscopy. And that involves putting in a scope into the pleural space so that we can actually see around the pleura and take strips of pleura off for biopsy. But in order to get your scope into the pleural space, you need a sort of space to exist. And therefore, there needs to be some pleural fluid left in that space to get that scope in, if that makes sense. So really, if you did the patient what you thought was a favor and took all the fluid off, you'd actually virtually eliminate the pleural space, thereby making it virtually impossible to do a subsequent thoracoscopy. So that's why we say no drain until you've got histological confirmation of what exactly is going on with this patient. In terms of other investigations, I think we've sort of covered that really with sort of the pleural fluid send off. So the patient also needs a CT scan, because clearly we're thinking about cancer here, so staging CT would be indicated. So staging CT essentially is a full scan from neck to mid-abdomen to look at the whole of the lungs, but also the reason it goes to mid-abdomen is because common sites of lung cancer metastases include liver and adrenal glands. So that staging CT will help to look for anything like that. As we mentioned, some sort of biopsy is important, so there's different options. Thoracoscopy would be appropriate. If a CT scan confirmed there was a tumor within the bronchial tree, then bronchoscopy might be an appropriate way of getting histology. If it's a very peripheral lesion, then the radiology team may be able to assist by doing a CT-guided biopsy. And if it's something more mediastinal or very deep inside, or if it's very close to, for example, a major sort of important blood vessel, then you might need to consider getting a surgical biopsy done to minimize the risk of complication. So with all those results, the next step would be the multidisciplinary team discussion, and you'll learn more about these probably in year 4 in the cancer block. Just really to mention at the moment. It's essentially a team comprising of oncologists, physicians, surgeons, specialist nurses, palliative care, if that's appropriate, um, you know, and a wide variety of healthcare professionals who essentially are going to help somebody, not only in the diagnostic pathway, but in terms of treatment options for cancer, if that is the case. And like I said before, once the histological diagnosis has been proven, if it does turn out to be cancer, then a full chest drain may be appropriate, and something called pleurodesis, which essentially involves putting a talc infiltrated solution into the pleural space, which then causes inflammation of the two pleura, the visceral and parietal pleura, and that causes them to stick together. And that essentially will minimize the chances of further pleural fluid developing if, for example, the patient has an underlying cancer. So trying to prevent subsequent effusions developing, because if that happens, then they have to go through the same process of having some sort of pleural intervention if they become symptomatic again because of increasing size of pleural effusion. Okay, the next case, and this is the last patient on our virtual ward round. Patient 5 is a 67-year-old man who's referred from the GP walk-in centre to CDU because of 6 days of cough, green sputum and fever. He is talking in full sentences. His blood pressure is okay at 140 over 85, maybe it's slightly high. His pulse is 112, temperature 37.8, respiratory rate 32. And initially his SATs are 92% on air, so he's given some controlled oxygen, 28% oxygen, which improves his saturation to 97%. Blood sugar is also down on arrival, which is normal. So really, the reason for the transfer from the GP walk-in centre to CD is mainly because of the low saturations. Otherwise, the GP would have probably considered giving the patient some antibiotics if appropriate, and then discharging. So when we take a bit more of a history on CD, we confirm the same story, but just going through the background. He's also got previously diagnosed hypertension. He's on Ramapro. He's got penicillin allergy, previously causing a rash. And in terms of family, his father died of myocardial infarction when he was 70. The patient himself is an ex-smoker of 6 years, having accumulated 40 pack years in total. He's a retired shopkeeper. In fact, he was a newsagent, and he has a wife, 2 kids and grandkids, a pet dog, but no known asbestos exposure. So examining this patient, again, the observations remain the same. He's not confused. His mini-mental test score, or abbreviated mental test score, is 10 out of 10. He is a little bit breathless on talking, but normal percussion note. He's got some right-sided chest crackles, bronchial breathing as well on the right side. And also on the right side, it's noted that it's got some increased focal resonance. He's got a sputum pot by the bedside now, which has got some evidence of green sputum in it as well. So really, as you'll realize, the signs that we're picking up here, the right-sided crackles, bronchial breathing, increased focal resonance, is suggestive of some sort of underlying consolidation. So given the story, the presentation, what's going to cause consolidation? Probably pneumonia in this case. So in terms of investigations, we want to get obviously an x-ray, relevant blood test, relevant cultures. He's slightly tachycardic, so an ECG would also be very appropriate. He was a bit hypoxic on admission, so again, an arterial blood gas would also be appropriate in this case. So the chest x-ray, we can see confirms a upper right mid-zone shadowing. There's also some small areas within the shadowing, which essentially are potential features of consolidation. So we've got air bronchograms, which exist, which are these little circular lesions, which you can see in the middle of that consolidation. So essentially, the report for this x-ray, given the presentation, knowing the history of the patient, would be right upper and right mid-zone, then shadowing with associated air bronchograms, and therefore suggests underlying consolidation. Given the presentation, this probably represents a pneumonia. However, the differentials, like we've mentioned before, should be also considered. Again, clearly lung cancer could present like this, and that's something that we'd really be mindful of and not want to sort of miss. But it's a very acute history with this patient. It's a very sudden onset over just a matter of a few days. So that potentially goes against any suggestion of underlying malignancy in this case. So looking at the blood tests, I've not given you all the normal values. You'll get to know those in time or in assessments you are given the normal reference ranges. So just looking at his results, the sodium potassium results are within normal ranges. Urea and creatinine are both high, suggesting some sort of renal impairment, and this would support an acute kidney injury. His CRP level is clearly very high, indicating quite a significant infection, and that's also supported by the raised white cells and neutrophil count. Looking at his blood gas, we can see that he's on controlled oxygen, 28% oxygen. And as a result of that, he's got a normal pH and he's got normal PO2, bearing in mind he's on oxygen, and his CO2 is also within the normal range. He's had a variety of cultures sent, but we haven't got the results of those back yet. So blood, urine, and sputum cultures have been sent. So really putting all that together, this does appear to be a case of pneumonia. So therefore, we need to think about the severity of the pneumonia. So we've got our scoring system, which is very useful, which is the CURB-65 scoring system. So just briefly, can you think what this patient's CURB-65 score is, looking at his clinical details and presentation? So he has got a CURB-65 score of 3. So I've underlined the areas that our patient is positive for. So his urea was above 7, his respiratory rate was above 30, and his age is above 65. He is not confused, therefore he doesn't get a point for that, and his blood pressure is essentially within normal limits for somebody of his age, so he's not getting a point for that either. So the next question is, how is the CURB-65 score useful? Well, knowing his CURB-65 score has two main benefits, really. One is that your local and even sort of national guidelines will give you guidance on how to treat your patient based on what the CURB-65 score is. And the second benefit is it's also a mortality predictor. So this slide really shows us that. So 30-day mortality can be predicted as per the CURB-65 score. And clearly, the higher the score, the worse the potential outcome. So our patient has CURB score of 3, which equates to about 17% 30-day mortality. So it's quite high, but clearly you can see it gets worse the higher your CURB-65 score is. And this is a local Leicester algorithm from our local guidance, which is useful because it really essentially tells you how to manage a patient in terms of treatment according to their CURB-65 score and their allergy status. So we know that our patient has a CURB-65 score of 3 and he is allergic to penicillin. So therefore, it's telling us that we should give this patient intravenous meropenem, 500 milligrams QDS, along with oral doxycycline, 200 milligrams once a day. So very useful to sort of look at that. And again, wherever you work, there will be a similar algorithm, but this is part of our Leicester pneumonia care bundle. So really taking that care bundle into consideration, the management of this patient is going to be controlled oxygen, IV meropenem, oral doxycycline, and as per any medical admission, as long as there's no contraindication to doing so, prophylactic deltaparin to try and reduce any risk of thromboembolic disease. And then eventually, it's going to probably take a few days at least of treatment for this patient to improve. The discharge criteria really should be obviously normalized observation. So in other words, off oxygen, normal sats on air ideally, improving symptoms, and really a significantly improved CRP as well would be certainly my advice before I discharge a patient like this. What's the follow-up? Well, again, each local trust will have its own arrangements, but again, Leicester, as part of the pneumonia care bundle, we have pneumonia specialist nurses who will arrange a follow-up chest x-ray 6 weeks after the initial x-ray is done, so the patient can go home, have an up-to-date x-ray in about 6 weeks' time to make sure that all of that consolidation has resolved. But clearly, if it's not resolved, you may have concerns that there's something else going on apart from just standard pneumonia. And the causes of non-resolving pneumonia are quite wide. It really depends on again, more information from your patient, but it might be some sort of complication that wasn't foreseen in the first place. For example, have they developed an infection in the pleural space as well as the lung parenchyma? That's called an empyema. Have they developed an underlying lung abscess? Is the reason that the consolidation not improving because the patient is immunocompromised, in which case we should certainly think about checking HIV tests and immunoglobulin levels. And certainly for anyone under the age of 40 being admitted with pneumonia, we should definitely be checking these tests. In terms of antibiotic, have they had the right dose? Did they take the treatment? Again, you may have decided to give your patient a 5-day course of antibiotics for the pneumonia. You may have discharged them on day 3 with the proviso that they take the further 2 days at home. They may not have done that, or they may have forgotten to do that, or maybe that they took the treatment but they just didn't absorb it very well. Again, there may be some reason why they haven't absorbed their antibiotics. Always organisms, so again, unless you've done a sputum culture, you may not know exactly what the organism is, and if we don't look for things, then we're not going to find anything. And it may be that actually this is a more resistant organism, or maybe an atypical organism that we haven't considered, and therefore the antibiotics that we actually prescribed were not adequate to cover that organism. S is some sort of secondary diagnosis, so cancer we've mentioned already, clearly would be a big concern if somebody has an ongoing consolidation after 6 weeks on their x-ray despite having had proper pneumonia treatment. P can cause changes with an x-ray, hemorrhage, localized bleeding for different reasons, or something called organizing pneumonia, which can be a consequence of infection, which can lead to significant inflammation in the lungs, which actually needs a longer course of antibiotics, sometimes additionally steroids as well to try and suppress that. So this is quite a useful slide, really, just to think about cause of non-resolving pneumonia. So just going back to the patient, so you've got to imagine that our patient was on the ward and actually, he's just had a dose of IV antibiotics. And then this happens, the nurse calls you to see the patient, and clearly it looks like he's having an anaphylactic reaction to his antibiotics. So what would you do? Well, clearly, it's something which it can escalate very quickly, anaphylaxis, particularly if the upper airways gets obstructed. So, get help quickly, senior help or some other colleagues to come and sort of give you a hand. If the patient is deteriorating very rapidly, then clearly you may need to call the arrest team. But if the patient is still stable and you can do a few things on your own, then certainly remove the trigger. In other words, stop the IV antibiotics. Again, using basic life support, maintaining the airways. So again, thinking about ABCD approach for looking and assessing your patient. But in terms of treatment, they need things given fairly quickly. So, most, in fact, all arrest trolleys should have this equipment on it if you can't get it anywhere else. So, intramuscular adrenaline can be given 0.5 milligrams straight away, which can be repeated every 5 minutes or so if required. The patient also needs IV steroids, IV hydrocortisone, 200 milligrams, and intravenous antihistamine, which typically use chlorpheniramine, 10 milligrams. And again, if they're hypotensive, you can think about fluid resuscitation, lying your patient flat, for example. If they are very wheezy, you might think about giving a nebulized bronchodilator like salbutamol. And more specialist care, probably from ENT or anesthetics, if they notice laryngeal edema, they might also consider adding in some nebulized adrenaline. So that's it, really. So we've survived our virtual ward round. We've sort of gone through 5 separate cases. So really, at the end of any normal shift, whether that be a day shift or a night shift, that will sort of conclude with some sort of handover to the next team. So in our example table here, we've got a few things that we've sort of discussed, and we'll hand over to the next shift. So in summary, we've been through a few cases. Please use the information from the presentation to help complete your respiratory cases in your main workbook. And again, don't forget to use the supplemental respiratory booklets. And please discuss any questions you've got, particularly about anything I may have said, with your clinical teams, or if you feel that they aren't able to address your questions, then let me know. Thanks for watching.